On pulmonary circulation. Let's start by talking about the pressure in the pulmonary circulation. You should know that the pulmonary circulation is a low pressure system, much lower than what you find in the arteries of the body. For example, as you know, a normal systemic blood pressure is about 120 over 80. In contrast, a normal pulmonary artery pressure is about 24 over 12. For this reason, the walls of the pulmonary arteries are very thin relative to arteries on the systemic side of the body. They have less smooth muscle, they have less resistance to flow, and they are very distensible, meaning they are very compliant. This also has implications in our heart. As you know, the left ventricle is much thicker than the right ventricle, and that's because the right ventricle only needs to generate pressures like 24 over 12. It doesn't need to have enough muscular strength to generate high pressures like 120 over 80. The pulmonary circulation responds differently to changes in blood oxygen content from the systemic circulation. In the systemic circulation, if there's a low oxygen level, a low PaO2, this is going to cause vasodilation of blood vessels, and the idea here is that tissues want to increase blood flow to bring more oxygen in when they sense that there is hypoxia. In the lungs, it's the opposite. When there's a low oxygen level, this leads to vasoconstriction. Low oxygen levels are directly sensed by smooth muscle found in the pulmonary vessels, and this cuts off blood flow. This is called hypoxic vasoconstriction. And the idea here is that our body has evolved so that blood is shunted away from poorly ventilated areas. This allows more blood flow to go to the well-ventilated areas. And where this is very important is during fetal development. In the fetal circulation, there's relatively low oxygen content, and that constricts the pulmonary arteries in the womb. This allows the blood to circulate to other organs that are growing and not grow through the lungs, which aren't providing any oxygen when the baby is in the womb. After the baby is born, the pulmonary arteries and blood vessels begin to receive more oxygen, and then they dilate, and then we get more blood flow through the lungs. So if you were to graph the oxygen content of blood on the x-axis and the blood flow on the y-axis, for the lungs it would look like this blue line here. As the PaO2 goes up, there's more blood flow. In the systemic circulation, it's the opposite. As the PaO2 goes up, there's less blood flow, and when the PaO2 falls, that's when those vessels dilate to really increase the blood flow. Now let's do a brief review of gas exchange as blood moves through the lungs. Shown on this slide is a pulmonary capillary in red with blood flowing from left to right. It flows past an alveolus, shown in blue, with oxygen coming into the blood and carbon dioxide leaving. The gas content of the air that we inspire if we're at sea level breathing normal 21% oxygen air is 150 millimeters for partial pressure of oxygen, and there's essentially no carbon dioxide in the inspired air of our atmosphere. Once air gets to the alveolus, the concentration changes. Carbon dioxide is added, and the carbon dioxide partial pressure goes up to 40, and oxygen is removed, and it mixes with carbon dioxide, and the oxygen content falls to 100. Blood coming into pulmonary capillaries comes from our venous system. It has a very low concentration of oxygen because oxygen has been consumed for metabolism by tissues, so the partial pressure of oxygen in venous blood is about 40 under normal circumstances. The carbon dioxide content is relatively high. It's usually about 46. That's because carbon dioxide is produced by metabolism. And then the blood moves through the pulmonary capillary, exchanges gas with the alveoli, and when it leaves, a normal partial pressure in the artery for oxygen is about 90, and a normal partial pressure for carbon dioxide is about 40. And this difference of 90 in the arteries compared to 100 in the alveoli is called the AA gradient, and I talk about that in detail in the video on hypoxia. So now that we understand that, we can talk about how gases are exchanged between the alveoli and the bloodstream. So gases like oxygen or carbon dioxide can be classified by the limiting factor for gas transfer within the body. To understand this, let's look at the bottom right side of the screen. So imagine that we have carbon dioxide found in venous blood. That venous blood is delivered to the lungs. This is perfusion of the lungs. Once the blood gets to the lungs, carbon dioxide has to diffuse out of the blood into the alveoli and establish equilibrium with the alveoli. Well, if the limiting factor is the blood flow delivered to the lungs, the perfusion, then we say that gas is perfusion limited. This means that the more blood flow we have, the more gas we will transfer, and that the total amount of gas that is transported depends on perfusion. More blood flow leads to more uptake of gas if gas exchange is perfusion limited. On the other hand, if the diffusion of gas out of the bloodstream into the alveoli or vice versa is what limits the total amount of uptake of gas, then we say that that gas is diffusion limited. And this means that gas transport, the total amount of gas going in or out of the bloodstream, is limited by diffusion, not by perfusion. To understand this better, let's look at this graph I've drawn on the screen here. Along the x-axis is the length along the pulmonary capillary as blood moves from the venous side of pulmonary capillaries over to the arterial side, where blood is exiting the pulmonary capillaries, heading into the left atrium and the arteries. Along the y-axis, I've shown the partial pressure of gas, basically the concentration of gas in blood. So what I want you to do is imagine that we administer nitrous oxide to a patient. Normally there's no nitrous oxide found in our lungs or in our bloodstream, but we're going to administer nitrous oxide to a patient to do an experiment. So what we're going to do is administer nitrous oxide and establish an alveolar concentration of nitrous oxide of P sub A right here. So inside our alveoli, nitrous oxide will be at this concentration. And now we're going to examine how the concentration of nitrous oxide changes as blood flows along the pulmonary capillary and picks up nitrous oxide from the alveoli. And if we were to do this experiment, we would find a curve that looks like this. So initially, venous blood enters the pulmonary capillaries with no nitrous oxide because we don't normally have any in our bloodstream. But as blood flows along the pulmonary capillary, it picks up nitrous oxide from the alveoli and it quickly reaches equilibrium where the concentration in the blood, which is the blue line here, is equal to the concentration in the alveoli. And when a gas behaves like this, we say it is perfusion limited. And nitrous oxide is the classic example of a perfusion limited gas. And you can establish this experimentally by looking at how quickly the concentration rises as blood flows through a capillary. If we were to do the same experiment, but instead of nitrous oxide, we administered carbon monoxide, we would find a curve that looks like this. So once again, we don't normally have any carbon monoxide in our bloodstream, so the venous blood would enter the capillary with zero carbon monoxide content. But as it moved along the capillary, it would pick up carbon monoxide from the alveoli, but it would never reach equilibrium with the alveoli. Gases that behave like this are said to be diffusion limited. Because diffusion is limiting the gas uptake, it can never reach equilibrium with the alveoli. That's the hallmark of a diffusion limited gas. And carbon monoxide is the classic example of a diffusion limited gas. So it's nice to know that nitrous oxide is perfusion limited and carbon monoxide is diffusion limited, but what about oxygen, a gas that is very important to our body? Well, first of all, when the venous blood enters pulmonary capillaries, the concentration of oxygen is about 40 millimeters of mercury. It is not zero like for carbon monoxide or nitrous oxide because we always have some oxygen in our blood, even in the venous system. In a healthy person at sea level, the alveolar concentration of oxygen is about 100 millimeters of mercury. And if we were to look at how oxygen content changes as blood moves along a pulmonary capillary, we would get a curve that looks like this. So oxygen does reach equilibrium with the alveoli, and that means that in healthy lungs, oxygen is perfusion limited. There are, however, pathologic processes which impair the uptake of oxygen, and when that happens, we can get something that looks like this. For example, pulmonary fibrosis impairs diffusion of oxygen into the bloodstream. So in patients with pulmonary fibrosis, they can develop hypoxemia, and this happens because oxygen switches from being perfusion limited to being diffusion limited, and therefore it never equilibrates with the alveoli, and the partial pressure of oxygen when it leaves the lungs, in other words, when it leaves the pulmonary capillaries, will not be 100, it will be some value lower than that, and that represents hypoxemia. If a person ascends to high altitude, the atmospheric pressure of oxygen is much lower, and therefore the partial pressure of oxygen in the alveoli is much lower. It can get as low as 60 if you climb to certain heights. When this happens, oxygen transfer into the lungs is still perfusion limited. However, the highest it can get is 60, that value in the alveoli, and therefore we develop hypoxemia, not because of any shift from perfusion to diffusion limited gas transfer, but because the atmospheric oxygen content becomes lower and therefore the alveolar oxygen content becomes lower. And shown here is the curve for carbon dioxide. So carbon dioxide in the venous blood, which is entering pulmonary capillaries, is usually about 46 or so. It depends on the metabolic activity going on. As blood moves along the pulmonary capillary, it releases carbon dioxide and therefore the level falls and it equilibrates with the alveoli, and therefore carbon dioxide, just like oxygen, is also normally perfusion limited in terms of gas exchange. In clinical practice among patients with lung disease, the DLCO is commonly measured. The DLCO is the diffusing capacity of carbon monoxide. This is a measurement of the ability of the lungs to transfer gas. The way this test is done is the patient inhales a small amount of carbon monoxide. You may know that carbon monoxide is dangerous, but the amounts used in this test are very small and not dangerous. Because carbon monoxide uptake is diffusion limited, the amount taken up by the lungs is equal to the diffusing capacity of the lungs. So the patient inhales carbon monoxide, then exhales gas from the lungs, and the machine measures the amount of carbon monoxide exhaled. Patients who have lung disease that results in a significant impairment of diffusion will not take up much carbon monoxide. On the other hand, healthy lungs will take up more carbon monoxide. There are normal amounts predicted for age and body size, and a normal result is about 75 to 140% of the predicted value. Patients who have severe forms of lung disease that impair diffusion can have values like less than 40% predicted. In the video on hypoxia, I talked about how diffusion impairment can lead to hypoxemia in the blood. And I went into great detail talking about how the volume of gas taken up by the blood is proportional to the area for uptake of gas times the difference in partial pressures divided by the thickness. I won't go into all that now, but I will point out here that there are some classic disorders which have a low DLCO value. Those disorders are all associated with diffusion impairment. So patients who have emphysema have destruction of their alveoli and they lose surface area, and therefore the amount of gas that they can uptake by diffusion is limited. Patients who have fibrosis or pulmonary edema develop thickening of the walls of the alveoli, and this also limits the diffusion of gas. So in all of these disorders, emphysema, fibrosis, or pulmonary edema, the DLCO is going to be low, and the reason it's going to be low is because the test uses carbon monoxide, and the uptake of carbon monoxide by the lungs is diffusion limited. Let's talk about the resistance to blood flow as blood moves through the lungs. This is referred to as the pulmonary vascular resistance. In terms of resistance to blood flow, there are basically two types of vessels. There are alveolar vessels, which are the capillaries that surround the alveoli, and then there are extra-alveolar vessels, which are the arteries and veins that supply blood to the alveolar capillaries. Just like my drawing on the screen here, an alveolar vessel, which is a capillary, supplied by an artery and drained by a vein. When the volumes in the lungs and the alveoli increase, it has different effects on the alveolar and extra-alveolar vessels. Higher lung volumes tend to crush the alveolar vessels, and this causes them to have high resistance. Basically, they're smushed so that their diameter becomes very small, and this causes a lot of resistance to flow. However, at higher vessels, the extra-alveolar vessels, like the arteries and veins, are pulled open, so they actually have lower resistance at higher lung volumes, and this is just a quirk of our pulmonary system. The capillaries tend to want to have less air, and the arteries and the veins tend to want to have more air. The two can't both be happy, so our resistance goes up and down as air comes in and out during the respiratory cycle. And it turns out that if you plot the pulmonary vascular resistance, the resistance to blood flow during the respiratory cycle, you find that it is at its minimum at the FRC. So once again, the FRC is a very, very important capacity in our lungs. I talk about this quite a bit in the video on pulmonary physiology. It's a point where the tendency of the airways to collapse is perfectly balanced by the tendency of the chest wall to expand, and it's also the point during the respiratory cycle where the pulmonary vascular resistance is lowest. For the rest of this video, I'm going to talk about pulmonary hypertension. So the normal pulmonary artery pressure, as I mentioned earlier, is about 24/12, with a mean pressure of around 10 to 14. The definition of pulmonary hypertension is a mean pulmonary artery pressure greater than 25 millimeters of mercury. And for step 1 of your exam, one of the most important things to know is that the classic physical exam finding of a patient with pulmonary hypertension is a loud P2, meaning a loud pulmonary component of the second heart sound. They may say the patient has a loud P2, they may just say the patient has an accentuated or loud second heart sound. It's classically heard best at the left upper sternal border, and so if you read a description of any of these things, they are trying to tell you that the patient has pulmonary hypertension. The main symptom of pulmonary hypertension is dyspnea. When there are high pressures in the pulmonary artery, blood cannot flow normally to the lungs, and that will lead to the onset of dyspnea. Especially with exertion, patients will complain of limited breathing when they try to exert themselves. The reason pulmonary hypertension is so dangerous is that if it's untreated, it can lead to what's known as cor pulmonale. Cor pulmonale is the consequence to the right ventricle of chronically elevated pulmonary pressures. If pulmonary hypertension is left untreated, the right ventricle will hypertrophy. Eventually, it will become dilated and it will fail, and this will lead to all the signs and symptoms of right heart failure that I talk about in the cardiology videos. Patients may develop jugular venous distension, they can develop lower extremity edema, and they can develop swelling of the liver, which leads to hepatomegaly on physical exam. And untreated, this can eventually lead to heart failure and arrhythmia and death. And so they're going to want you to know this in step 1. In a patient with pulmonary hypertension, what is the point of treating the condition? And it's to prevent right heart failure and death from heart disease. The gold standard for a diagnosis of pulmonary hypertension is a right heart catheterization. This is where catheters are inserted into the pulmonary artery and the pressure is measured directly. Now, this is an invasive procedure and we don't like to use it unless we have to. So you can make a non-invasive diagnosis by echocardiography. An echocardiogram shows you the right and left ventricle and the right and left atrium as shown in this picture here. You can see if the right heart structures are enlarged. That's a sign of pulmonary hypertension. And there are also methods to estimate the pulmonary artery pressure using the flow speed of blood moving through the right ventricle by echocardiography. Pulmonary hypertension leads to arteriosclerosis, which is thickening of the walls of the pulmonary arteries. This occurs because chronic blood pressure elevation in the pulmonary arteries causes smooth muscle cells to proliferate. This thickens the medial layer of the pulmonary artery and narrows the lumen. So if you look at this picture on the screen here, this is an example of medial hypertrophy next to a normal example on the right. And you can see that the medial layer here is thickened, and that's going to narrow the lumen for blood flow, which is going to make blood flow through the lungs even worse. Now we're going to talk about the different causes of pulmonary hypertension. And the easiest way to understand this is to look at the flow equation, which I've shown on the screen here. This equation tells you the determinants of the pressure in the pulmonary artery. It's equal to the cardiac output times the vascular resistance plus the pressure in the left atrium. So if you know this, then it's easy to understand that anything that either raises the left atrial pressure or raises the pulmonary vascular resistance can cause the pressure in the pulmonary artery to become high, and that's pulmonary hypertension. To understand this better, let's draw a pair of lungs here, and we've got blood flowing into the lungs at the pressure of the pulmonary arteries. We've then got blood leaving the lungs, and the pressure when blood leaves the lungs is equal to the pressure in the left atrium, because blood leaves the lungs and goes into the pulmonary veins and then the left atrium. So whatever the left atrial pressure is, that's the pressure of blood leaving the lungs. And then finally, the flow resistance as blood moves through the lungs is the pulmonary vascular resistance. So if you understand this, then it's easy to appreciate that if the vascular resistance goes up or if the left atrial pressure goes up, these two things are going to cause the pressure in the pulmonary artery to become high, and that's what leads to pulmonary hypertension. So back to this slide, causes of pulmonary hypertension that are due to an increase in left atrial pressure are the most common causes of pulmonary hypertension. When high left atrial pressure leads to pulmonary hypertension, this is called pulmonary venous hypertension. And it gets this name because pressure is high in the pulmonary veins, which are connected to the left atrium. And all the causes of pulmonary venous hypertension are things that have to do with the heart, things like heart failure, valve disease, and we'll talk more about that in a minute. The other way you can get pulmonary hypertension is if the pulmonary vascular resistance goes up. When this happens, we call it pulmonary arterial hypertension. And the reason it gets this name is because when the pulmonary vascular resistance goes up, pressure will be high in the pulmonary arteries, but it will not be high in the pulmonary veins and the left atrium. Therefore, we distinguish this from pulmonary venous hypertension by calling it pulmonary arterial hypertension. And there are both primary and secondary forms of elevated pulmonary vascular resistance that cause pulmonary arterial hypertension. We'll talk more about that in a minute. So let's talk about pulmonary venous hypertension. This is always due to diseases involving the left heart. So blood flows into a pulmonary capillary, like I've shown here, with a pressure of about 25/12. That's a normal pulmonary arterial pressure. It then leaves and the blood goes into the pulmonary veins and into the left atrium, and a normal pressure in the pulmonary veins and the left atrium is about 5. If something happens in the left heart and the pressure in the left atrium goes up, this pressure in the pulmonary veins, instead of being 5, could become 20 or 25 or even 30. When that happens, that pressure is going to be transmitted backwards, and you're going to get high pressure in the pulmonary arteries. And when this happens, we call it pulmonary venous hypertension, and it's always due to left heart disease. So as I said before, left heart disease is the most common cause of pulmonary hypertension. This is what we call pulmonary venous hypertension. It's always related to high left atrial pressure, and you can get this from heart failure, you could get this from mitral stenosis, you could get it from mitral regurgitation. Any valvular condition or heart failure condition that raises the pressure in the left atrium is going to lead to pulmonary hypertension, and that's the most common reason that patients develop pulmonary hypertension. Less commonly, patients develop pulmonary hypertension from a high pulmonary vascular resistance. And as I told you before, we refer to this as pulmonary arterial hypertension. And there are a number of reasons that patients can develop a high PVR. One of the most common is chronic hypoxemia. In the lungs, hypoxemia leads to vasoconstriction. The lungs try to vasoconstrict blood flow in the setting of hypoxemia to divert blood to healthy portions of the lung where there's more oxygen. So patients with chronic hypoxemia from COPD or other chronic lung diseases can develop pulmonary hypertension because the vasculature in their lungs is chronically vasoconstricted. This can also happen to patients with sleep apnea who have episodes of hypoxemia while they sleep. It can also happen to patients who live at high altitude. These patients can be chronically exposed to hypoxia, and that can lead to pulmonary hypertension. Another reason patients can develop high PVR is if they have chronic pulmonary emboli. Some patients with hypercoagulable states develop recurrent emboli to their lungs, and this shuts off blood flow to portions of the lung, and this leads to a decreased area for flow because portions of the lungs are not perfused with blood. And when you decrease the area for blood flow, you increase the pulmonary vascular resistance. There are also many patients with pulmonary arterial hypertension from high PVR who do not have chronic lung disease and hypoxemia, and also do not have chronic thrombosis. Many of these patients have one of these conditions I've written on this slide here. These conditions are all commonly associated with high PVR and pulmonary hypertension. One of the ones you will most frequently encounter clinically is connective tissue disease. Patients who have scleroderma often develop a high PVR and pulmonary arterial hypertension. Patients with late-stage HIV infection can develop pulmonary hypertension. Congenital heart disease associated with shunts can chronically flood the lungs with high flow as blood comes from the left to the right in a shunt. Eventually, this can cause high PVR and the shunt can reverse. That's called Eisenmenger syndrome. And I talk about that in the videos on congenital heart disease. Infection with the helminth schistosomiasis is associated with pulmonary arterial hypertension. And then PAH has also been described in patients who chronically use drugs like amphetamines and cocaine, which are vasoconstrictors. Idiopathic pulmonary arterial hypertension is a rare disease that classically affects young women. It's caused by high PVR, but it occurs in women who do not have any of those conditions I showed on the last slide. That's why it's called idiopathic. We don't know exactly why this happens, but there's lots of basic science literature that describes increased activity of vasoconstrictors like endothelin and decreased activity of vasodilators like nitric oxide. And probably these things work together to cause high PVR in women who have idiopathic PAH. There is a path finding that's unique to idiopathic PAH that you should know for step 1. It's called the presence of plexiform lesions. This is a plexiform lesion shown on the slide here, and what you see is a blood vessel which has multiple lumens. All these red areas are different lumens of the blood vessel. And the reason this happens is because there's endothelial proliferation formed from the high pressure in the lungs, and as the endothelial cells proliferate, they start to create multiple lumens within a blood vessel. And this usually happens in small artery branch points where the medium arteries are branching down to smaller arteries. A classic finding in biopsy of a lung or examination of a lung postmortem in a patient with idiopathic PAH. Another high-yield thing to know about idiopathic PAH is that it is sometimes associated with gene mutations in a gene called BMPR2. That stands for bone morphogenetic protein receptor type 2. This gene codes for a protein that inhibits smooth muscle proliferation. So if it becomes mutated, you can have abnormal growth from abnormal smooth muscle proliferation. This can occur in the endothelium, in smooth muscle surrounding the vessels, and because you have excess growth, that can start to narrow the lumen and cause an increase in PVR. Mutations of this gene are seen in up to a quarter of idiopathic cases of PAH, and there are rare familial cases of idiopathic pulmonary arterial hypertension, and up to 80% of these familial cases have a mutation in this gene associated with the disorder. There are a number of treatments for PAH. These are all designed to lower the PVR so that you lower the pulmonary arterial pressure and protect the right ventricle. These can be used in patients with idiopathic PAH. It's also used in PAH associated with connective tissue disease and other conditions. One of the oldest drugs used to treat PAH is epoprostenol, which goes by the trade name prostacyclin. It's an intravenous form of prostaglandin I2, which is a potent vasodilator. And the idea here is that because it's IV, you infuse it directly into a vein and it goes straight to the lungs and causes vasodilation of the blood vessels in the lungs. It has to be given continuously through a central line, and it's very difficult for patients to take this medication. Nowadays, we have several oral drugs that can be used. The first one is bosentan, which is an antagonist of endothelin-1 receptors. Blockade of these receptors leads to vasodilation. And the second one is sildenafil, a drug that's also used for erectile dysfunction. It can be used in patients with PAH because it inhibits PDE5 in smooth muscle of the lungs, and that lowers the pulmonary arterial pressure. And that concludes our module.